Hello everyone, this is 14th MCQ. Now in the stem of MCQ, an infant is brought to the OPD by his mother for the complaints of feeding difficulties, excessive sweating over the forehead and recurrent episode of cough and fever. So this history part suggests that patient is having the acyanotic congenital heart disease, in which generally patient is having the difficulty in the feeding, excessive sweating over the forehead, especially during the feeding time, is characteristic of the congenital heart disease, and recurrent episode of cough and fever suggests patient is having the recurrent respiratory infection. Again, it suggests patient is having the acyanotic heart disease. Now in the general physical examination, infant had characteristic faces. So here in this image you can see upward slanting of the eyes, mongoloid slant, flat nasal bridge, open mouth, protruded tongue, short neck, and this is moon-like faces. So characteristically seen in the Down syndrome. So the patient is having Down syndrome with acyanotic congenital heart disease. Now in systemic examination, patient is having tachycardia, tachypnea, retractions, hepatomegaly with hyperdynamic precordium, systolic thrill at lower left sternal border, accentuated S1, wide fixed splitting of S2 and harsh apical hollow systolic murmur which radiate to axilla. So go one by one. Tachycardia, tachypnea, retraction, hepatomegaly can be because of congestive heart failure. So patient is having signs of CCF. Now hyperdynamic precordium visible whenever there is a volume overload condition. It can be seen in the non-cardiac condition also or in the cardiac. So in the cardiac it can be because of VSD, MR, PDA, or in non-cardiac because of anemia, thyrotoxicosis. So here patient is having acyanotic heart disease. So maybe it is because of VSD, PDA or MR. Now, systolic thrill at lower left sternal border means in the fourth, fifth left side intercostal space just lateral to the sternum. So this is characteristically seen in the ventricular septal defect. So patient is having VSD according to the systolic thrill and hyperdynamic precordium. Now accentuated S1. Accentuated S1 seen with the MR, TR. So we should think that patient is having VSD with MR. Now wide fixed splitting of S2. It is seen in either atrial septal defect or in the right bundle branch block or in the TAPVC, total anomalous pulmonary venous return. So here according to the history, patient is having acyanotic heart disease, not having cyanosis. So TAPVC is ruled out because TAPVC is a cyanotic congenital heart disease. Now according to the wide fixed splitting, patient is having ASD or right bundle branch block or both. Harsh apical hollow systolic murmur which radiate to the axilla. It is seen with the mitral regurgitation. So according to this part, patient is having ASD plus VSD plus MR. ECG is showing the superior QRS axis minus 40 degree, biventricular hypertrophy and right bundle branch block. So what is the diagnosis? So we cannot say only ASD because patient is also having the signs of VSD and MR. And in ASD, ECG will show the right axis deviation with the right ventricular hypertrophy. RBBB can be seen with the ASD also. So ECG is also not supporting only ASD. Now in the VSD, left axis deviation with left ventricular hypertrophy, later on biventricular hypertrophy can be seen, and RBBB is not common with the VSD. It is not seen with the VSD. Now in the PDA continuous machinery murmur will be audible in the pulmonary area. Patient will have the hyperdynamic precordium and ECG will show the left axis deviation in the PDA and left ventricular hypertrophy, or later on biventricular hypertrophy can be seen. So again, it is not in the favor of PDA because there is no continuous machinery murmur audible in the pulmonary area. So it is ruled out. Now the last option is endocardial cushion defect. What is it? It is the complete AV canal defect or sometimes partial AV canal defect. So endocardial cushion defect in which patient will have the ASD plus VSD plus AMR or TR. So the right answer is ECD. And most common congenital heart disease in the Down syndrome is endocardial cushion defect. So according to this and according to the finding, this answer is the right answer for this MCQ. So similarly in the same MCQ they can ask, stem will remain same. In angiocardiogram, gooseneck deformity is seen. So it is characteristic feature of ECD. This MCQ is asked in NEET SS 2017. Gooseneck deformity is seen in which condition? So the right answer is endocardial cushion defect. So in this image you can see this is angiocardiogram and showing the characteristic gooseneck deformity. So the learning points are complete endocardial cushion defect in which patient will have the ostium primum ASD plus VSD plus cleft in mitral and tricuspid wall. So here in this image you can see this is atrial septal defect, this is ventricular septal defect, and the cleft in mitral and tricuspid wall lead to the single atrioventricular wall. So this is common wall between both atria and both the ventricle. 70% of the children with the ECD have the Down syndrome, or we can say it is the most common congenital heart disease in Down syndrome patient. In ECD, ECG will show the superior QRS axis between -40 to -150 degree because having ASD with VSD with MR with or without TR. Increased PR interval because of first degree AV block, and patient will have the right ventricular hypertrophy, right bundle branch block with or without left ventricular hypertrophy. RSR pattern seen in the V1 lead. So this is characteristically seen in the ECG. Now in X-ray, patient will have the cardiomegaly because of involvement of all four chambers. Increased pulmonary vascular marking will be there, and in echo and angiocardiogram characteristically show the gooseneck deformity. So here in this X-ray you can see it is characteristically similar to this gooseneck, so label as a gooseneck deformity. And the treatment for the ECD is they should be operated during infancy, preferably between 2 to 4 months of age, as they are having the chances of heart failure and recurrent pneumonia, and if not operated timely then they will develop the pulmonary vascular obstructive disease by the age of 6 to 12 months. So mortality is very high if not operated early. So they die without operation by the age of 2 to 3 years. Thank you so much.